Thanks everyone for joining us. Thank you for joining us. So we want to welcome Dr. Nikita Shah, Medical Oncology Team Leader at Orlando Health, UF Health Cancer Center. I think that covered everything there.
Yes.
Dr. Shah, thank you so much for joining us.
My pleasure.
We had a lot of questions this week from people who want to know about various things in the breast cancer fight. But the first thing I want you to talk about, when a patient hears those words, "you have breast cancer," what is the first thing as an oncologist that you want the patient to know?
Probably the most important thing is that this is not going to kill you. Because obviously when you hear the word cancer, the first thing that comes to everybody's mind is, am I going to die from this? We know that with early stage breast cancer, the cure rate is over 95, maybe even closer to 99%. So when we talk of mammogram saving lives, that's exactly what it does. A mammogram catches a cancer early, at which point, yes, you may have to go through treatment, but you're going to be cured from your cancer. So a breast cancer diagnosis is not a death sentence.
And when patients hear those words, though, that's the first thing that comes to mind for many people.
Absolutely. So I think it's reassuring that early stage breast cancer is very, very treatable. And having said that, even advanced disease, even metastatic disease nowadays is very treatable. We have some really excellent treatments. And we tell patients that, think of it as a chronic disease, kind of like diabetes or heart disease. You're going to live with this diagnosis for years and years, hopefully even decades.
All right, so let's talk about breast cancer. What is it exactly? How would you describe to someone what is breast cancer?
So in our body, and this is true of all cells, we have this perfect harmony of the good and the bad, and we have all cells that have a particular lifespan. When something changes that harmony, so you have more cells being made and less being destroyed, these cells just kind of accumulate. They don't die like they're supposed to. And that essentially is the basis of cancer. So these cells, and they grow, and then they clump together and they can form what we call tumors. So uncontrolled growth, or the cells not dying, essentially is what cancer is.
When we think of breast cancer, is this just one disease, or are we talking about a lot of different things that become breast cancer?
And that's the other thing I stress to my patients, that breast cancer is not the same. There are many different subtypes of breast cancer. And I'm just going to give you a quick overview on what that is. So when you hear somebody saying breast cancer, first we look and see, where did the cancer begin? Did it begin in the ducts of the breast or the lobules of the breast? It could be called ductal or lobular. They're, for most purposes, treated about the same way, but they have a little bit of nuances. Then the other big determinant is, and obviously we're only talking about invasive breast cancer at this point. The other big determinant that we look at is something called estrogen and progesterone receptors. So normal breast tissue have these receptors, and then the cancer cells hold on to these receptors. If the cancer is very mutated, it's a high-grade tumor, it may lose the receptors. So if a tumor is estrogen and or progesterone positive or driven, then one of the treatment options would be to block estrogen from stimulating those cancer cells, the normal tissue around it, but more importantly, any cells that may have escaped. So a patient who has ER and or PR positive breast cancer would be put on hormone blocking pills that they would take for minimum 5 years, maybe longer. That more data seems to suggest that longer may be better. Then we have the next thing we look at, and probably one of the most important things we look at, is a gene that's amplified on the cancer cells called HER2/neu, HER, the number 2, and EU. About 20 to 25% of all breast cancers express this gene. And cancers that overexpress this gene tend to be much more aggressive in their behavior. But having said that, today we have such good treatments for HER2-positive breast cancer that it's almost better to have a HER2-positive breast cancer. Our staging guidelines changed a couple of years ago. And actually, if you have a tumor that's HER2-positive, it downstages it, because these biologically, these behave better with the right treatment. So with the right treatment, HER2-positive tumors behave better. And if your cancer cell does not have either the estrogen receptor or the progesterone receptor or the HER2/neu gene, that's called triple negative breast cancer. So the 3 different things we check are not there. And this distinction is very important because the way these cancers behave is different, and that's why the way we treat them is very different. There are some other things that are being looked at, but purely that's more academic at this point, whether it's basal-like or not. We don't base any treatments at this point. Really, the things that we look at is the ER, PR, HER2. Then we look at something called the grade. how much do these cancer cells look like the normal surrounding breast tissue? Then we look at what's called Ki-67, that looks at the proliferation rate, how quickly these cells are growing. But again, treatment decisions are not made on those two. It's really the first three things, the ER/PR and the HER2. Obviously, then the size of the tumor and whether it's in the lymph nodes or not, which helps determine treatment.
All right, so how do you know if you need chemotherapy or radiation or both?
So again, broken down by subtype. So if you have a tumor that's HER2 positive, pretty much the standard of care now is, so at least I would say over a centimeter HER2 positive breast cancer, and if it's in the lymph nodes for sure, the standard of care is to do chemotherapy and antibodies against that HER2 new gene up front. The reason for that is these are biologically very aggressive tumors. So we don't want to focus on only what's in the breast. We want to focus on cells that may be floating around. So that's why these are the patients who get chemotherapy and antibody therapy up front. Then they have surgery. And then depending on the surgery, they may or may not need radiation. And typically those antibodies continue for a period of 1 year. If it's a triple negative breast cancer, means you don't have the estrogen and the progesterone receptors. That means the only way to treat this is with chemotherapy. Again, those biologically are more aggressive and they're going to be treated with chemotherapy up front in most cases. If it's an ER positive tumor and HER2 negative tumor, then unless the tumor is really, really large, what we tell patients is go ahead, have surgery first. We'll see what we find, and then we decide whether somebody needs chemotherapy or not. So in that setting, if the tumor is not very big, it's not in the lymph nodes, we can actually do some tests on the cancer cells that predicts the behavior of this cancer. It looks at the genetic makeup of the cancer cells, and this is different from genetic testing. Genetic testing is you're checking the DNA of the patient. Here we are checking the genetic makeup of the cancer cells. And the most commonly used test is called Oncotype DX. And that tells us what is the risk of this cancer coming back. And if the risk is high, then there's benefit to chemotherapy. If somebody has a lumpectomy, where they just remove part of the breast, they will almost always need radiation. So that is independent of the chemotherapy decision.
And I think that is very important to mention because a lot of times patients will compare their treatment plan to other patients. Someone may have chemotherapy first, but someone else may have surgery first. So you shouldn't think, oh, that person had surgery first. Why am I not having surgery first?
Right, and also the other thing to remember is that surgeries in the end is only a means to remove the cancer. So if somebody's going to need chemotherapy based on the biology of the cancer, irrespective of what kind of surgery they do, they may still need that chemotherapy. So sometimes patients think, oh, if I remove both the breast, I'm done, I'm cured, I don't need any more treatment. And yes, it may be true for certain scenarios, but for most scenarios, you would still need something else to reduce the risk of the cancer coming back.
How would you describe to people what chemotherapy is? When we hear chemotherapy, what is it?
So chemotherapy basically means medications that kill cancers. There are probably over now 250 different chemotherapy drugs. So each drug is different, each drug behaves differently, and each person's reaction to the drugs are different. So some have very predictable side effects, but because these cells, these kill cells that are growing rapidly, typically there are some predictable side effects where it lowers the blood counts. Some of them can cause hair loss, some of them can affect the heart. So every drug behaves differently. And again, you may hear of people who essentially, go through chemotherapy, no side effects, and then some have more. So everybody reacts differently also.
Is there a standard treatment for, say, that you would say for a patient going through chemotherapy? Because we hear about the ACT, protocol or treatment plan.
So when I mentioned the ACT, it's one of the most commonly used regimens. It's a combination of different medications. The A stands for adriamycin, C stands for Cytoxan, and T stands for Taxol. And that is still one of the most commonly used regimens. But depending again on the tumor subtype. So if it's a triple negative breast cancer, very commonly we add a drug called carboplatin to the Taxol. And if it is HER2 positive, we try and avoid the A drug, the anthracycline, because that can affect the pumping function of the heart, as can the antibody. So we want to avoid two drugs that may affect the heart. So for HER2 positive breast cancers, we usually use a combination of the two different antibodies called Herceptin and Perjeta, along with two different chemotherapy drugs called Taxotere and carboplatin.
You mentioned side effects. That's one of the things when patients hear about chemotherapy, they start to freak out because of the side effects. So tell us what's being done to lessen those side effects, because they can really be a bear for some patients.
Yes. And so the first thing I reassure patients is, number one, all these side effects are very short-lived. Yes, you will have side effects, because if somebody says you're not going to have side effects, not true. You're going to have some side effects. Everybody deals with it differently. Most of them are short-term. Most of them are for a very defined period of time, usually a few days after chemotherapy. And most of them are very, very manageable. So common side effects that we see, and again, it varies based on the regimen, maybe some nausea. The nausea medications are so good now that, when you hear of those stories of people sitting in a corner all day throwing up, that doesn't happen anymore. Maybe more of that pregnancy, queasy feeling is what we hear most. And even with that, there are so many different things that we can do. So in 2020, if a patient is having nausea or vomiting, I'm not doing my job right, because there are things that we can do. So there is no reason why a patient should still have nausea and vomiting in this day and age. Depending on the regimen, diarrhea can be fairly common. Sometimes it can be pretty significant. So we, sometimes if we know that a certain regimen is going to cause diarrhea, we give medications beforehand and we say, take this. Don't wait and see what happens. If you see diarrhea coming on, take it, because then you can fall behind on your fluids. Some of them have a potential for long-term toxicity. There's a very small risk, less than 1% risk of leukemias. Again, very small but real. So obviously that's something patients need to know about, but then you have to balance that with what you are gaining with the treatment. And typically we know that in breast cancer and the patients who need chemotherapy, it reduces the risk of the cancer coming back by probably 50, 60, 65%. So when you balance that with a less than 1% risk of leukemia, the benefit significantly outweighs the potential side effects. Some regimens come with hair loss, and I reassure patients that hair loss is temporary and hair comes back. I tell them, I don't promise you the color. I promise you it'll come back, but I don't promise the color. But really, those are the main side effects that we see. That probably the other thing that bothers patients is fatigue. Not fatigue where they can't function, fatigue where they'll be like, I worked all day, I didn't feel like going out in the evening. So they kind of have to learn to pace themselves. And that's what women find hard. They're used to being go, 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 and they're used to, working and taking care of their families and coming home and doing stuff. And now they're like, wow, I need to sit back and I need to take some time for myself. And that's what I tell patients. This is your time. Take care of yourself, because if you're not going to be able to do well and not tolerate chemotherapy, it's only going to make the path a little harder. So it's really important for women to listen to their bodies and say, this is the time. It's okay to reach out for help. It's okay to tell somebody else to do something for you. It's okay when your friend reaches out or a family member reaches out and says, let me bring you food. Okay, let them do it. That's okay. And sometimes a lot of older patients will say, but I don't want to be a burden to my children. And I tell them, what, this is payback for all the diapers you changed. It's okay. Let them help you, because you need that help. Even if it means that you have half a day when you don't have to do anything and you can put your feet up and watch TV, that's okay. That's your relaxation time. That's your me time.
Let's talk about staging. And this was a question that a friend of mine asked, because when her mother was diagnosed with cancer and they told her it was stage 4, she said the family was like, oh, okay. They didn't realize what that meant. So how do you stage breast cancer, and what do the various stages mean?
So stages basically helps us define a cancer and define its behavior. So if you talk to any oncologist, if I say patient has stage 2 breast cancer, they know what we are talking about. So really it's more a medical terminology when we talk stage, but it is very important also because it has prognostic implications. So if I tell somebody patient has stage 3 breast cancer versus stage 1 breast cancer, anybody that knows anything about breast cancer will know stage 3 means it's a more aggressive subtype or aggressive stage of the cancer. So stage 0 is when the cancer is non-invasive. So it stays within the duct. So stage 0 breast cancer by itself doesn't cause a problem. But if you don't treat it, if you let the cancer sit in there, it can become invasive breast cancer. So that's the reason we treat in non-invasive breast cancer or stage 0 breast cancer. Stage 1 is when the tumor is small, less than 2 centimeters and not in the lymph nodes. Stage 2 is if the tumor is over 2 centimeters in size or if there's lymph node involvement. Stage 3 is when the cancer is over 5 centimeters in size and there are 4 or more lymph nodes that are involved with the cancer. And stage 4 means the cancer has spread to an organ outside of where it started. So if the cancer started in the breast but now is in the lungs or the liver or the bones, that's called stage 4 breast cancer. So if somebody has breast cancer that they find in the liver, that's not liver cancer. That's still breast cancer in the liver. And why is that distinction important? Because liver cancer is treated very differently from breast cancer in the liver. Breast cancer in the liver is treated like breast cancer versus liver cancer is treated with some surgery or radiation. Stage 4 breast cancer, theoretically, as of today, is not curable. It is treatable and very well treatable for very long periods of time. But as of today, we don't have anything that we call a cure. We have treatments that are very, very effective, and we are seeing patients kind of have no evidence of disease for long periods of time, but we are not at a point yet where we can say they are cured. So that's why that early detection is so critical, because if you catch it in a stage 1 or 2 or even a 3, there's a chance for cure, a very high chance for cure, versus by the time it's stage 4, when it's found, it's not curable with what we know today.
That really has changed over the last, I would say, 20 years or maybe even last decade, that stage 4 does not necessarily mean that's it, go home and get your affairs in order.
Absolutely. Forget 20 years, I would say even in the last 2 years.
Wow.
I mean, every year, we have some new changes. Just this year, for one particular subtype of breast cancer, we had 3 new drugs that got approved. For another kind, we had 1 drug that got approved. So it is just, science is advancing very rapidly, and we are so grateful because now we have more and more options that we can offer our patients.
We're seeing a lot of younger women now who are being diagnosed with breast cancer.
Mm-hmm.
Women in their 30s, early 30s, even late 20s.
Mm-hmm.
Do we know what's causing that?
No, we don't. And, some of it is absolutely a true increase in the incidence. Of course, there's more awareness and better identification also, but there's definitely an increased incidence in younger patients. And we don't know, it could be environmental, it could be genetic, it could be who knows what, but we don't know. But yes, we are seeing more and more younger patients with breast cancer. Having said that, a woman in her 30s, her risk of developing breast cancer is still significantly lower than somebody who's 70 or 80 years old. And that is why that screening guideline says, don't stop doing mammograms when you hit 60 or 65, because that incidence actually increases. So when we talk of that 1 in 8 risk, it's a lifetime risk by about age 80. So a woman at 75 should, if she's in good health, should not stop doing her screening mammograms, because her risk at that point is about 1 in 10.
For those younger women, they are not having mammograms until they're 40. So if you're in your 20s or your 30s, how important is the breast self-exam?
So it depends who you talk to, right? So I'm going to give you my very prejudiced and biased view. Absolutely important. I tell my patients, you have your hands, you have your breast with you. Why would you not do a breast exam? What do you have to lose? The guidelines have changed. There was a study done out of China. I think there was they looked at workers in a factory and they polled them and they said, oh, well, breast exam doesn't help. I have so many patients that I see who had a normal mammogram 2 months ago, 3 months ago, and then felt something and went in for a mammogram and they found a cancer. It's not that the mammogram missed it. It probably didn't have either enough calcification in it to pick it up on a mammogram, or it may have grown rapidly. So there's no reason not to. So I still strongly recommend a 3-pronged approach. Obviously, starting at age 40, do annual mammograms, have a breast exam by a healthcare provider once a year, and do your monthly self-breast exam. For women who are menstruating, the best time to do it is about a week or so after the period ends. Your breasts are less lumpy at that point. For women who are not menstruating, just pick a day of the month that you remember, mark it on your calendar so you don't forget to do your breast exam.
How about the recurrence rates? What have we seen over the past couple of years about chances of cancer coming back?
So that is very stage dependent, right? So if you have early stage breast cancer, the risk of recurrence is significantly lower compared to late stage breast cancer. There was a meta-analysis presented probably about 3 years ago now, which showed that for women who were in the high risk categories, so larger tumors, multiple nodes, the risk of recurrence was even pretty high, even at 20 years. And that's why that 5 year is not a magic number anymore. And that's the reason why a lot more data seems to be suggesting that if somebody is on hormone blocking pills, because the ER positive tumors have that risk of the disease coming back even later, to not stop the pills at 5 years. And there are tests that we can do at that 5 year mark that determines what is the risk of the cancer coming back and do they benefit from continuing with the pills at that point. So not everybody needs to take it for 10 years or longer, but some, or maybe a large number of women are going to benefit. For triple negative breast cancers, the highest risk of recurrence typically is in the first 2 to 3 years. So for most triple negative breast cancer, once they are beyond that 3-year mark, the risk of recurrence is extremely small. I still tell patients, you've got to be vigilant and watch symptoms and watch, you know your body the best. Something doesn't feel right, don't ignore it. But the risk is much, much lower after that 3-year mark compared to an ER positive tumor where the risk continues and potentially even goes up after a certain age or certain time period.
A question that came in, if you've had a mastectomy, can the cancer still come back?
So yes, so when you talk about it coming back, it can come back locally, meaning on the chest wall, or we're talking of it coming back elsewhere in the body. So coming back elsewhere in the body would then make it stage 4 breast cancer. And yes, it can, because breast cancer and other cancers release these little small cells that we, as of today, don't even have a way of detecting, that can go and sit somewhere. And then for some reason, one day just decide to start growing. We don't know what that triggered it. We don't know why in some patients these cells may be there and vice others may not. So the cancer could come back elsewhere in the body. So the surgery per se has no bearing on the risk of the cancer coming back. It's what you do to treat the breast cancer is what impacts the risk of the cancer coming back. And that's why with larger tumors, even if somebody has a mastectomy, we still recommend radiation because they're at very high risk of the a cancer coming back on the chest wall. But in general, if you have early stage breast cancer and you have a mastectomy, the risk of the cancer coming back in the breast is extremely small. But that has no impact on the risk of it coming back elsewhere. And frankly, if it were to come back in the breast, if they have not had a mastectomy, you could still do a mastectomy and cure somebody at that point. Unfortunately, when these cancers come back, they don't come back in the breast. They don't come back in the other breast. They come back in the liver or the lungs or the bone, at which point it's not curable. And that's why aggressive treatment up front is important, because this is our one and only chance where we are ahead of the cancer, where we can actually prevent a recurrence. Because once there's a recurrence, we're always one step behind. We can't, as of today, make it go away.
Another question that came in, if you have reconstruction after a mastectomy, do you still get a mammogram?
So it depends on the kind of reconstruction. So number one, depends whether somebody has unilateral or bilateral mastectomy. So if they have just one breast removed and they have reconstruction, of course, you need mammograms for the other side. But if you had both the breast removed, there's no breast tissue left, then no. There's no mammograms aren't going to show anything. It's just going to show big white blobs of, fatty tissue or implant or whatever it may be. So no, so traditional bilateral mastectomy, you don't need mammograms. If there is any irregularity that is felt, you may need an ultrasound intermittently, especially if you feel something. If somebody has reconstruction where they have implants that are placed, then if they're silicone implants, FDA mandates that at the end of 3 years after having an implant, you need to have an MRI looking for leakage, because a silicone implant, when it leaks, you're not going to go flat, so you won't know that it's leaking, compared to like a saline implant where one day somebody wakes up and says, wow, what happened here? So that's a very visible change. So silicone implants need MRIs at the end of 3 years from surgery, and then every 2 to 3 years after that. That's looking for leakage. But outside of that, without any symptoms, no, you don't need any other imaging.
How do you know if you should be tested for the BRCA gene?
So there are certain criteria for genetic testing. Some just very general rules: under the age of 45 with breast cancer, under the age of 60 with triple negative breast cancer, if you have a family history of breast, ovarian, uterine, colon, prostate cancer, or if somebody has breast and ovarian cancer, or if somebody has bilateral breast cancer. So there's a whole slew of guidelines that the NCCN has put forward. And what I strongly recommend is it's not about doing the test, right? The test is just only a small part of that whole equation. What is important as a patient is to know, what do you do with that information? What does it mean for you? What does it mean for your family? So we have genetic counselors. We always tell patients, go meet with the genetic counselor, because what you don't want is the wrong test to be done, because insurance may not cover a second test. You need to, so because of all the implications, we refer the patients to the genetic counselor, have them talk to the genetic counselor. Number one, see that they really even need genetic testing. And then if they do, then the genetic counselor will proceed with testing.
If someone has an early stage breast cancer and the recommendation is a lumpectomy and radiation, but the patient is like, this whole thing freaks me out. I want to go ahead and have a double mastectomy.
Mhm.
As an, what do you tell them as an oncologist?
So I hear this every single day. So first I tell the patients, step back, think about where you are. I explain the pathologies. If it looks like they have a stage 1 breast cancer, I tell them medically, you could have a lumpectomy followed by radiation or a mastectomy, and they're both identical. So if you're the kind of person who's going to panic every time you need to have a mammogram, you're going to panic every time you feel something, and it's going to keep you up at night, then do the mastectomy, because you're doing it for the peace of mind. But do it for the right reason. Know why you are doing the mastectomy. And the other thing I hear is, oh, if I do a mastectomy, the cancer is never going to come back. And again, I tell them, no, it's what we do to treat the breast cancer is what's going to prevent the cancer from coming back, not what you do surgically. So in spite of knowing all that, if you still want to do a mastectomy, absolutely. In the end, you as a patient have to live with that level of comfort, whatever it may be. I have some patients who say, you know what, I don't want to ever do radiation. Then mastectomy may be their best option. But again, I remind them that sometimes even after mastectomy, you need radiation. So again, know why you are doing a particular type of surgery. And if you understand the implications and you still want to go ahead with it, absolutely. Because mastectomy, unfortunately, is not just one step, right? If you're just doing mastectomy, no other thing, no reconstruction, simple enough. But if you're doing reconstruction, it's ongoing. There are multiple steps to that process. There's risk of complications. So you have to factor all of that in. And let me just say one more thing. So the only type of cancer that is completely cured with bilateral mastectomy is stage 0 breast cancer, the DCIS. Because if somebody with DCIS has bilateral mastectomy, they're done. They don't need hormone blocking pills. They don't need radiation. Obviously, they don't need chemotherapy.
And for those who don't understand what DCIS is, can explain what
sure, that's the stage 0 breast cancer. That's where the cancer cells stay within the duct. So if you let that sit in there over time, it can become invasive breast cancer. But DCIS is called stage 0 breast cancer. That's the best end of the spectrum, typically detected on a mammogram.
Okay, and that's what you were describing when we were talking about staging.
Correct. Yes.
Do you see a time when cancer will be just a chronic disease? And you talked about this a little bit before, like what you mentioned, like diabetes, that you could be diagnosed with it and live with it for the next 40 years of your life.
Absolutely. I think we are there to some extent. Certainly we're not there. There are some biologies that are much more aggressive, but certainly we are heading in that direction. I have patients that I have taken care of since the year I started. So they're now in their 20th year of metastatic disease and still doing well and doing everything. So, certainly, yes, we are headed that way. But again, the big thing is to stress is when it is caught early, you don't have to worry about that. So that's why that screening mammogram, that self-breast exam is so important. Something doesn't feel right. Even if you just had a mammogram, I don't care. Go and have it looked at. Go to your doctor and say, you know what, I feel something. If there's any question, don't not follow up on that. We're seeing a lot of things where patients saw something earlier in the year because of the pandemic. Either they didn't want to go out or they thought that they could not have a mammogram done. And we're seeing patients with larger tumors now. So please, yes, with the pandemic, we want to minimize exposure to stuff, but don't not take care of something that doesn't feel right.
And when you look at the future, what gives you hope in terms of what we're doing differently to treat breast cancer or what's on the horizon?
Like I said, just this year, we have 4 new drugs approved for a specific subtype of breast cancer. I mean, 4 drugs in 8 months or 10 months is phenomenal, considering everything else that has happened. And there are some very, very exciting drugs on the market. So typically the way this works is most of these drugs will get approved for later lines of therapy in the metastatic disease setting. And then we start looking at them in clinical trials in early lines of treatment. Because our goal is, number one, obviously, we want to prevent somebody from ever having to go to a metastatic stage. But if somebody even is caught at an early stage breast cancer where they need treatment, we want to hit them with the most effective treatment now so that we never have to deal with a stage 4 diagnosis and having to, be on treatment essentially for the rest of your life. So that early detection is important, and participation in clinical trials in early stage is important, because how do we treat with the way we do today? There are women, hundreds and hundreds and thousands of women who participated in clinical trials. That is how we are where we are today. So thank you to all those women and men who participated in trials to get us to this point where we are today.
And so how do you get into a clinical trial?
Talk to your doctor. There are different centers will have different trials. So obviously, not everybody wants to be doing the same thing all the time, right? Because otherwise you'll never make progress. So we may have certain trials that the next location may not have. So a good site is clinicaltrials.gov. They list all the trials that are going on in the country. So you can look at that, but talk to your oncologist. Find out, am I eligible for a trial? And in oncology, you are not going to hit a trial where you don't get a treatment. If you have a breast cancer diagnosis, the trials are going to be where you are getting something or you're getting potentially something that is better. There are some trials looking at comparison to maybe what's called a placebo, but those are always with underlying treatment. So there's nobody who is not going to get treated for their breast cancer.
And speak to the people who think about clinical trials like, I don't want to be anybody's guinea pig. They're going to do something to me and it's going to kill me.
And that's exactly it, that these trials, you're not a guinea pig. You actually are having the opportunity of getting something that is probably better than the standard of care. And every trial is different. So, talk to your doctor about the trial, understand what the trial is. So phase 1 trial is we are still testing the drug. Does it really work? Phase 2 is when we say, okay, it looks really promising. Now let's see how well it's tolerated, where we should use it best. And then phase 3 is where we compare it with our standard of care. To say, okay, we do XYZ as a standard of care. Is this better than XYZ or is it the same? Or is it worse potentially? So you want to try and always, put it on, try and get on a phase 3 trial because that's more standard of care, especially for early stage breast cancer. In metastatic disease settings, sometimes we have to go to phase 1 and phase 2 because we've already been through the standard treatments and we are looking for something novel.
Is there a time limit? Like if you're in a clinical trial or for a drug, is it going to be a year from now before it's available for everyone? Or does it depend on what kind of trial it is and how well the patient?
Yes. It depends on the trial. So metastatic trials are obviously we get results sooner because those are, patients will be on a period of time and then they progress. So we get data sooner. The early stage trials take longer. Sometimes it can take up to a decade to get results back.
Well, I think you have covered so much important information for us. So I want to thank you again for joining us and with your insight and some very encouraging news about the new drugs that came for patients.
Thank you, Vanessa. And again, just a quick reminder, don't think about breast cancer only in October, right? So do your monthly breast exam. And if something doesn't feel right, you know your body, don't ignore it. Get attention. And if you find that you're not getting the attention you need, go to somebody else, but don't ignore yourself and don't ignore symptoms.
All right, Dr. Shah, thank you so much for joining us.
Thank you, Vanessa. Have a great day.